So first of all, what are the number of seniors, assuming we have 8% of the 80-year-olds that have atrial fibrillation, what percentage of them qualify for the Watchman? That's the first question. And then what percentage are treated successfully? And then if there are any complications of the procedure, I mean, those are things that everybody would want to kind of understand and know. And then I'll get into some other generic questions afterwards.
Absolutely. Great question. So I think the first thing to say is that blood thinners do work in the vast majority of patients, and they work well to prevent strokes. However, that group that you mentioned, those above 80, by virtue of their age, already they're at a higher bleeding risk. Now, if you add in the fact if they're females, if they're small, meaning low body weight, if they have any kidney problems, and if they've had a high risk of recurrent falls, or they're at high risk for fall, they all fall under the umbrella of high bleeding risk. And in those patients, that risk-benefit ratio of the blood thinner starts to shift in towards a higher risk, less benefit. And so I think that group of patients, just as the first group, is great for Watchman. If I say a percentage that are eligible, I would say 40% of patients above 80 who have atrial fibrillation would be off the bat candidates for the Watchman procedure.
Great, thanks. I'm going to basically ask 2 or 3 quick questions because we have several other very eloquent speakers to follow. So I'm not going to take more than 2 more minutes of everybody's time here. And if there are any further questions, please, feel forward to, please feel free to ask any number of questions from the audience or elsewhere. So one thing goes on to the next, which is the aortic stenosis segment that you talked about, which is where the aortic valve, where you said it's really tight. That's also an elderly problem. Perhaps a smaller percentage of elderly patients have that aortic valve problem, and you and I know very well. So question is, how many people and what percentage of people of those aortic valve type valves that are seen in 80s and 90-year-old patients, what percentage qualify for that, and what is the associated comorbidities? And the last question to follow up is, what percentage require pacemakers after that?
Great questions. So I think I would say over the age of 75, about somewhere between 6 and 7% of patients will have aortic stenosis. Now, once we define that degree of narrowing, because it's a spectrum of disease, as severe, and we do that with echocardiograms, as you know, and the presence of symptoms, and any of those symptoms that I mentioned, the shortness of breath, the fatigue, the dizziness, the heart failure symptoms, we know that 50% of those patients with severe symptomatic aortic stenosis, if left untreated, will be dead within 2 years. It's a significant problem. Now, as I said, previously open heart surgery was really the only option, but those patients, by virtue of their age and all the other medical problems, are high risk for open heart surgery, not to mention the invasiveness and the recovery. So I would say 90 to 95% of patients we see with severe symptomatic aortic stenosis are eligible candidates for the less invasive transcatheter aortic valve replacement, which I showed. Pacemakers are a potential risk, and it varies depending on the nature of the device we put in, but also where the valve is positioned, and that's related to operator experience. I position my valves higher on purpose to minimize the risk of pacemaker. In the literature, the risk ranges from 6 to 15 to 20%. I will tell you at Stanford, our risk of pacemakers is less than 5% overall.
Great, thanks. Now there's some folks in the audience that have asked some questions. I'm going to try to address a few, and then I'm going to probably ask, they're generic, they're very interesting questions, and I'll have you answer a few of them.
Sure.
So one of the questions is, well, the first question I'm going to answer last, which is how to keep your heart healthy in old age. And we'll talk about that as a common denominator. But this next question very quickly is, I'm 75 years old, underwent angioplasty or stenting in 2003. I'm still on clopidogrel and aspirin for 17 years. Is it okay? The answer is 1 year of Plavix and aspirin is adequate. From there on, aspirin alone is good enough. So hopefully that answers the question. Rahul, any comments? Yes? Okay. Next question is, how do we know our arteries are blocked? What kind of heart test would you recommend? And what is the there's no single best test. You do an EKG, you do a stress test, you look at other options. And then you eventually, after screening, you can either do a myocardial perfusion imaging, which is a thallium or adenosine-related test or ragadenosine-related test, whatever else. And then lastly, you consider a CT angiography or a coronary angiography. Any other points you'd like to make?
No, I would say, and I think I said this last time, is if you are at risk, make sure you have a good cardiologist. It's people like Dr. Suri who know what test to order and when. That's the most important thing you can do, is have a good cardiologist.
Great. Now,
Definitely,
there's another
definitely.
question here about, is drinking wine good for health and how much? And then to follow up, why do some cardiac patients drink less water? I'll let you answer those two.
So like most things in moderation, and there's been a lot of literature that has said red wine is good, and there was things saying red wine is bad. I think the truth, like most things, is somewhere in the middle. The healthy recommended amount to drink for an adult male is 2 to 3 drinks, 2 to 3 times per week. Standard drinks, that is, so a glass of wine. And now there is a caveat. If you have an underlying heart condition which is precipitated by alcohol, such as an abnormal rhythm, or you have heart failure, then that doesn't apply to you. And so, it sort of has to be individualized. And then, sorry, the second question,
Second
Sam.
one was, why do we restrict fluids in patients for?
Oh, right. So in certain patients, and this is that group of patients with heart failure, the heart is unable to cope with the same volume of fluid as a normal heart. And so you will be advised by the dietitian, by the nurses, and by the doctors to restrict your fluid intake and also your salt intake in order to limit the strain on the heart and prevent a fluid buildup in your lungs and elsewhere.
Great. So one of the questions that was asked by the same person were, are there any side effects of taking clopidogrel 75 milligrams for a longer period? And my view is there are no major side effects. If you've got other comorbidities, including peripheral vascular disease and such, or cerebrovascular disease, then certainly you can continue Plavix for a lifetime. Rahul, any comments?
No, I completely agree. I think overall there are minimal side effects, and some patients may benefit from long term. But as you said, the absolute requirement is just for 12 months of the clopidogrel and aspirin thereafter.
Right. And another specific question from an anonymous attendee was, I'm 76 years old. I've had 2 MIs, 2 heart attacks. I've had 6 stents, it should say, since last year, and my heart rate is low. In the morning, when I wake up, it's between 48 and 50, and then it sort of goes up to about 60, hovers around there between 59 and 61. I do walk. I don't feel any complications or any such thing, but my wife says my breathing is louder than she can, louder and she can hear it. Can I have a valve problem? So maybe you can address this issue, because it could be an issue of heart failure or maybe chronotropic incompetence.
Yeah. So I think, unless the issue of heart rate, it may be related to the medications your doctor has you on. And in most instances, some of these medications are helpful to the heart. And as part of it, they reduce the heart rate to allow the heart time to fill and make it more efficient. And so unless you're actually feeling symptoms from that low heart rate, it's actually quite reasonable potentially to have a heart rate that's in the high 40s to low 50s. If, however, you're feeling dizzy or lightheaded or tired with that heart rate, then maybe adjustments need to be made to your medication. I think the breathing that your wife may be hearing could be related to extra fluid on board, particularly in the lungs. The other thing to think about is obstructive sleep apnea, which is very common in patients who have cardiovascular disease. And it may be worth raising that when you go to see your primary care physician or your cardiologist about whether you are at risk for sleep apnea, but also to inquire about your medication dosages and to titrate those accordingly.
Great. I think there's 3 other questions. Maybe the other speakers can address this. This question might be for Yogendra. Do I need to wear the device for 24 hours? The answer is 24/7. What is the question? I mean, what is the answer?
Well, the idea is you never know when things are, but from our perspective, we want to do an analysis in the real life conditions. So we want to know how is your heart and blood oxygen level in particular, and if you have missing beats, we want to do that analysis. And people talk about heart rate variability, but you as cardiologist, you will agree the true measure of heart rate variability is through the interbeat intervals, not change of heart rate over time. So we do that, and essentially based on heart rate variability, other parameters, lifestyle conditions, we develop what we call it a heart rate variability index, and eventually a heart health score. So longer you wear it, the better it is.
Thank you. I have 2 questions. These can be addressed by Ashish, I think, and then perhaps if Dr. Rahul Sharma wants to take this on, that would be good. These relate to intermittent fasting, and perhaps Sandeep, you can address one of these issues as well, but I'll start with Ashish. For intermittent fasting, what was the fasting time period and what is best? Ashish, perhaps you can start and Sandeep can address it. And then the other question for Ashish, it's how to reverse blood pressure.
The question on intermittent fasting, I mean, the traditional approach is to kind of get 16 hours of fast and 8 hours of a period in which you eat. And the big question for most people are, is that the 16 hours may span the time period over breakfast, which also is a recommended lifestyle behavior for heart health. So let me have Sandeep answer the question based on his timings, because he actually did it. And then I can come back and talk about how that can be implemented.
Yeah, so intermittent fasting, I did it for some time. I did that, generally made sure that I ate by 8 o'clock. And, because again, the good thing is when you're at home, you're able to control it. Because of COVID, you're at home, you're eating at the regular time. So you can eat finish your meal by 8 o'clock, and then the next you have it by 12 o'clock. The next day. So that's the 16 hours. But what I've really found beneficial over the last 1 year is doing the Ekadasi fasting and fasting for, every 2 weeks. And this is again, some might say religious but a lot of our scriptures and Ayurveda, there is always a scientific reason. And there was Ekadasi fasting is generally done every 2 weeks. It's 24 times. And if you look for the scientific reason, there is something called autophagy, which is won by a Nobel Prize winner. A Japanese doctor has won that. So the advantage is for Ekadasi fasting, I generally don't fast completely. I eat sagudana, I avoid grains. And that has really helped me, because that is for 24, I avoid eating chapati. I just eat fruits, and I'm very disciplined on those days. And there is also a reason, because of the moon. The 11-day Ekadasi is the 11th day of a waxing moon and the waning moon. And there is the gravitational energies of what you eat and the grain. There is a Hare Rama, Hare Krishna explanation for that. But, there is also a medical, if you Google autophagy. So that is something, if some people can't do intermittent fasting, this is something which one can really do it. But again, both work well. Yeah.
I was just going to say that one of the things that we kind of recommend is also to have breakfast daily. So that kind of comes in conflict with the intermittent fasting to some extent in the cycle that Sandeep talked about. But there is a way to kind of do the intermittent fasting where the 8 hours start at breakfast time and then continue till the late afternoon. So if you're able to kind of get your dinner in early by 4 p.m. or something like that, then you can kind of, also incorporate the breakfast, which, from a glucose regulation standpoint, becomes a better way of the intermittent fasting. There's a lot of research being done on this right now. People have expressed that they lose weight with intermittent fasting. So we are researching this as well and studying this to see kind of what the impact is and what the new studies are regarding intermittent fasting. And we are hoping that we can do an ICC talk on intermittent fasting, considering that there's so much interest on this particular topic in health as well.
I have one more question. I think this is from Mr. Bakshi. Naren is in Jaipur. Strange, no answers, but all extensive heart tests show me or proof that I'm in great heart health, but my heart rate goes down to the 40s and even as high as the 90s. Is this an athletic heart? Because he's very active, I know. Or am I, and should I use I am on a continuous monitoring chip with Medtronic. So maybe I can take on a little bit of this question, and then Rahul, you can address the other issue about the chip. And then finally, Yoginder, maybe I'll get Yog's idea about what this could mean, eventually. And then there's a follow-up question, which is unrelated to this, that would be for Rahul. So the question from Naren Bakshi is very valid. I think that he's very well conditioned. He works hard to do this. And Naren, if you're there, please speak for yourself. So this way it'll be very clear. If not, I can answer some of those questions for you. But I think that heart rate variability is a good thing. I think having the Medtronic chip or perhaps any other implantable loop recorder, implantable cardiac monitor to assess for cardiac arrhythmic risk is a reasonable thing, and particularly if somebody is symptomatic, for example, symptomatic palpitations, unexplained syncope, or if people faint unexplained in an unexplained way, or if they have had a prior stroke or mini stroke. Those are the indications primarily for this, or after a catheter ablation. Rahul, you might want to address some of the issues of what the indications for ILR or ICM are at this point. Then we'll go to you.
Yeah, I think, there's a lot of benefit in, as some may or may not know, there's various levels of monitoring, from the in-hospital bedside EKG, which is just a quick snapshot, to a longer-term monitoring like a Zio patch or a Holter monitor, which can be up to 2 weeks. And then the Link, which is the Medtronic device, the small device that is for longer-term monitoring, is particularly useful because it's small, it's safe, it's very quick, like an outpatient day procedure type situation in 15, 20 minutes, but it gives you up to 3 years. And that's very useful for patients whose symptoms are very infrequent. And so you might not be able to catch it on the day of an EKG or a 2-week period of monitoring in another way. So I think in those sorts of patients where you have infrequent symptoms, it's very useful to try and pick up arrhythmias.
Yog, would you want to address the issue of chip technology for implantable chips versus your non-invasive technology that you are you're certainly done well on?
Yeah, I agree that the longer monitoring is a good thing. So chip is definitely as long as you can get it, but there are certain constraints and they optimize for power. So I am not sure under all conditions you get it. One of the things is if there is an incidence, the report goes out. Otherwise, once every 1 hour is what you get the report. But I agree that longer monitoring is better, but that's for people who have an advanced diagnosis. For us, using it a wider population, non-invasive, a lot cheaper solution would be able to find larger identification of potential problems. So it's more on a preventive side, so that you can find it before the incidence happens rather than post-incidence.
This might be the last question, and that is it okay or reasonable for folks to take clopidogrel, aspirin, ramipril, and metoprolol? These are medications primarily for cardiac disease, who do Ekadasi fasting. And so Sandeep had talked about Ekadasi fasting. I'm not very familiar with it, but perhaps Sandeep can elaborate a little bit more. But the answer, as far as I'm concerned, is absolutely yes. The question might be, could there be any bleed because of clopidogrel, aspirin when you're fasting? The answer is certainly can, but I think that it's you should not be stopping your medications for one reason or another, and that's the point. Rahul, one quick comment, and then maybe we'll take it to Sandeep about Ekadasi fasting.
Completely agree. Never stop any of your cardiac medications without consulting with your cardiologist, but I'll defer to Sandeep for the intricacies of that fasting modality.
Yeah. So the thing is, the Ekadasi fasting is, the way I do it is I have fruits. Generally, it's not that I'm not eating. I generally avoid grains, rice. So it's just like a discipline. I eat sagudana khichdi. So that is what it is. What the thing is, the autophagy is something. What happens is the way, what the research, the Nobel Prize, there's a Japanese. If you just do autophagy, it's AUTOPHAGY. So Nobel Prize was won in 2016. So what they say generally is that 24 days, they have done research that if you fast for 36 hours and for 24 times, 20 to 24 times a year, you have anti-aging benefits. It has very good benefits. And so what the 36 hours is like, basically your previous night, you sleep at 8 o'clock and then you sleep and then the next day you fast and then you don't eat it. But the Ekadasi fasting, one can't do that. That is, a little bit difficult. What I tend to do is I tend to have only fruits, and I have this sagudana thing, and it works quite well because I also don't do emotional eating those days, because sometimes you're emotionally eating, since you're at home, you go pick up something. But those days I've become more aware that I don't eat. I'm more disciplined. So that every twice a month it happens. So I do it from a religious perspective, but I don't go with religion completely. I like to understand what it is, and I like to look at medical things also. So I've seen the health benefits. So for each his own, but if you want to know more research on that, the autophagy, Nobel Prize 2016, you Google that, you can get more, and it will be helpful also for both, the medical community and, South Asian art also to look into it and, do more research on that. That's the way I go.
Thank you. One short further question, and maybe Rahul and I can take this for like 10 seconds because I think we're running completely out of time, but thanks, we can continue this on a different segment. And that is, my friend has a normal stress test with an abnormal EKG. Is that okay? And Rahul, you might want to just give it a quick shot at it. And there was another question follow up for you, Rahul. So it's abnormal EKG, normal stress test. And then the next question follow up is, I'm an engineer. I marvel the engineering behind deploying devices, but is there any way to minimize intervention?
Okay, so first question, abnormal EKG, normal stress test. Without looking at the EKG, an abnormal EKG can range from the benign abnormal, which is just a variation in human health and anatomy, all the way to the abnormal that requires further investigation. A stress test, like any test, is not 100% perfect. And depending on the conditions, we talk about the sensitivity of a test, which is the ability to detect disease. And depending on the nature of the stress test, it can be anywhere from 60 to 85% sensitive, which means it could miss 15 to 40% of disease. That's the short answer. So really, we need a bit more information. But again, have a good cardiologist that goes through your test results with you.
Right.
The second question about minimally invasive, we are in an exciting era of interventional cardiology where, as you can see, we're now able to replace valves through an incision this big, through an artery or a vein. We are still trying to get smaller and smaller. Of course, modifying lifestyle factors and preventative aspects will help you get into these states. But unfortunately, sometimes, regardless of your best efforts at diet, lifestyle, some of these are not preventable at all. And so you may still end up requiring a procedure. And so I think in the appropriate setting, you shouldn't delay the need for a procedure if indeed it's warranted.
Thank you.